All right. Any questions before we start any new content today? Anything you need clarified from previous lectures, anything like that? No, nothing? Okay, if you change your mind and you have questions, you know you are welcome to ask me anytime. I am coming to you from Miss Fisher's office today, so I am on campus. I'll be back through on my way home. Today we're going to talk about tobacco and smoking because it used to be that tobacco was really the only kind of smoke, but now there's tons of different kinds, right? So we had to add and smoking and how it relates to periodontal disease. So how many of us know somebody who smokes or uses smokeless tobacco? Yeah, it's very, very common, right? What are some things you know about that? What are some adverse health effects from tobacco?
Oral cancer.
Okay, cancer, specifically oral cancer. What else?
Heart disease.
Good. Cardiovascular disease. I'm just going to put CVD there.
Lung disease.
Good. Lung cancer. We can have all kinds of issues, right? There's lots of concurrent diseases that come along with using tobacco. So let's talk about how this is a risk factor for periodontitis. What do y'all think? Why would tobacco cause periodontitis?
Could one be dry mouth?
Good, xerostomia, absolutely. And we know that when the tissues are dry, they're not as healthy, right? They're at higher risk for periodontitis. Very good. Thank you, Alexa. What else? What have we talked about before for smokers? What does their gingival tissue look like?
It doesn't bleed, does it? Or it's less
Good.
likely to bleed?
It doesn't bleed as much as a patient who's not a smoker. Do you know why?
It's more fibrotic.
Good. It's called fibrotic tissue. What do we know about blood flow to the mouth in people with tobacco use?
It's constricted.
Good. Vasoconstriction. That's going to be a big theme today, vasoconstriction. So let's break down what the word means. What does constrict mean?
Tighten.
Tighten, right? And vaso, what are we talking about?
Blood flow.
Good. The blood vessels specifically, right? So if we constrict the blood vessels, we have less blood flow to the periodontium. What comes in the blood? Why do we need blood flow to the periodontium?
Oxygen.
Oxygen, okay. What else?
Nutrients.
Nutrients, good. What travels through the bloodstream to site of infection?
White blood cells.
Good. White blood cells, specifically PMNs come first, right? Well, if we don't have enough blood flow, we're probably not going to get enough PMNs to that area either. So there are a lot of things that go along with vasoconstriction that make tobacco a risk factor. So there are lots of different delivery methods for tobacco. Cigarettes are very common. Chewing tobacco, right? Smokeless tobacco. Snus, is it called snuff or snooze? You know what I'm talking about? That brand. Yeah, I see some of you nodding your heads. Okay. Cigars, pipes. Most people don't use pipes anymore, but they're still out there. They're still available. So first, we're going to just talk about our professional responsibility. How many times have y'all, I mean, maybe you haven't run into this yet, but if you've worked in a dental office before and you say to your patient, hey, we need to talk about your smoking habit, what do patients say?
It's not a habit.
It's not a habit. It's none of your business. I'm not going to quit. Don't waste your breath. I'm not going to quit, right? But I want to instill in y'all that, come on in. Here's Miss Fisher. I want to instill in you that this is our job. So even if a patient says, I don't want you to give me tobacco cessation today, you need to say, I understand your opinion, but this is my job. And in order to do it correctly, I need to deliver this information to you. Don't be snippy about it. You know, they're less likely to take in the information when it's said that way. So smoking and tobacco use are major risk factors for periodontal disease. What kind of risk factors did we call these? Do y'all remember?
Was it systemic? I don't know.
Yeah, it is systemic. That's right.
Modifiable.
There it is, Anne-Marie. Thank you. Modifiable. This is the number one. I can spell. There we go. Modifiable. Number one modifiable risk factor for periodontitis, because patients can quit. They can't quit having an autoimmune disease or type 1 diabetes, right? But smoking, they can quit. So this is known as a modifiable risk factor. So let's talk about some statistics here. Patients who smoke are at a 2 to 3 times higher risk for periodontal disease. They're more likely to lose their teeth than non-smokers. They're more likely to exhibit attachment loss and destruction. So remember the line where we go from gingivitis to periodontitis. Smokers are likely to have periodontitis quicker and more severe than non-smokers. And smoking could be responsible for up to 50% of cases of periodontal disease in the US. Does that surprise you? 50%, half of periodontitis in the US is from smoking. So there are a lot of reasons we learn about this, and this is just a couple of them, but you have to have the information you need to back up tobacco cessation with your patients. It's not enough to say, quit because I said so, right? How many of you are likely to stop doing something because your parents said so? You're likely to do more, right? You would go the opposite direction. So if we don't have the information in the research to back up what we're telling our patients to do, it really doesn't mean much. So what are the oral issues? Halitosis. What is halitosis?
Bad breath.
Good. It's like chronic, all the time, bad breath. We already talked about dry mouth. How about staining? Do you think that tobacco stain is intrinsic or extrinsic?
Does it start out as extrinsic and can it turn into intrinsic?
Yes, that's exactly right. So we can see brown extrinsic staining, or we can see yellow intrinsic staining over time. Periodontal disease and cancer. What are some of the most common spots that we find cancer in the mouth?
Hard palate.
Okay, sometimes we see it on the hard palate,
The tongue.
the tongue, the base of the
Right.
tongue, right? What was that? The floor of the mouth. So base of the tongue and floor of the mouth are two of the most common spots. And tobacco use only exacerbates that, only makes it worse. So here are some clinical pictures that I really love. Check out that. It's just like tar, right? How would we remove that? What do you think the best method of removal would be for this?
Maybe the Cavitron.
Okay, so Cavitron, some kind of ultrasonic instrumentation. What else?
Pumice.
What was it? Pumice, yeah. Pumice with a rubber cup. This, my friends, is where air polishing comes in handy. We can literally sandblast all that stain away. Now, we talked about cardiovascular disease. If you were to have a case, a case study where your patient has cardiovascular disease and tobacco staining, we'd have to be really careful about air polishing, right? Because what is the air polish powder sometimes made of?
Sodium bicarbonate.
Sodium bicarbonate, good. So you can see how these comorbidities kind of go into these case studies. Now, how is this patient looking?
Cleaner than the top.
Okay. When you look at this radiograph here, is that bone loss in the coronal third, the middle third, or the apical third of these teeth?
Apical third.
Good. So we've lost more than 50%. We've lost more than 66%. What's the prognosis for this patient?
They're probably gonna lose their teeth.
It's very poor, yeah, if not hopeless at this point. Now, what do you remember from the implant chapter about placing an implant for a patient who smokes?
Not
It's not
until they're
good.
stop.
Yeah, it's contraindicated, right? We would not recommend placing an implant for a patient with a smoking habit. So that takes away a whole replacement option for this patient. And their teeth are definitely not going to last much longer. So this is where smoking really has, taken a toll on the periodontium. So did you know there are more than 4,000 toxins present in cigarette smoke? 4,000. Some articles say more than 7,000, but your book goes with 4,000, so we're sticking with it. We also find more pathogenic bacteria in plaque biofilm for smokers. Why is that? What kind of bacteria is more pathogenic? Let me give you a couple options. So there's gram positive, there's gram negative, there are aerobes, there are anaerobes. Which of those would be the most pathogenic?
Aerobes.
No. Remember, aerobes have oxygen and anaerobes can survive with no oxygen. So where would we see no oxygen?
Underneath the gum line.
Good, in a pocket, right? In a periodontal pocket. Now, if a patient is smoking and we've caused vasoconstriction, less PMNs coming to the area, there's going to be more pathogenic bacteria present because it's not being resolved by the immune response. Does that make sense? All right. So favorable environment for anaerobic bacteria. Effects of smoking on the periodontium, like we've already talked about, the microbial biofilm, there are some studies that talk about major differences, but for the most part, this isn't a major implication. What we're most worried about is the xerostomia, the vasoconstriction causing these issues. The major point to take away from this slide is that there might be a decrease in the good bacteria in our mouth, in the bacteria that need oxygen to survive. So the bad bacteria, fungus, these things can all get out of balance if the good bacteria can't survive. Okay, this is all red. What does that mean?
It's important.
It's important. Beep, beep, boop, boop. If you weren't paying attention, now's the time. Effects on the immune system. So tobacco affects both the immune and inflammatory response systems. We see decreased signs of inflammation. So we know periodontitis is usually painless. If a patient doesn't have pain, they're not seeing any bleeding when they brush or floss, what's going to tell them they need to go to the dentist office? Nothing. We're losing all these signs. We also see decreased gingival curvicular blood flow. We already talked about that. Vasoconstriction. I promise you're going to see that word again. Neutrophil function impaired. What are the neutrophils we're concerned about here?
PMN.
PMNs, good. What's important about PMNs?
They're the first there at the site of infection.
Good. First to arrive to site of injury or infection. Okay. So if we have decreased adherence, decreased chemotaxis, and decreased phagocytosis, what does that mean for the periodontal pathogens involved in the inflammatory response?
There's nothing there to fight off the
Good.
bug.
There's nothing there to start that response. There's nothing there to fight the bacteria. Very good. So this can also cause a decrease in antibody production. Do you remember talking about immunoglobulins and antibodies? Remember IgG? What does IgG do? Somebody knows. IgG. Remember there's IgM. What does M stand for?
Major.
Major, because it's large and it's first, right? IgM is the first time we're exposed to an antigen. We produce IgM. Now, all subsequent exposures, what do we produce?
Antihistamine.
Okay, antihistamine from mast cells, but which immunoglobulin?
IgE.
Actually, it's IgG. So if we have decreased IgG production, our body isn't recognizing those pathogenic bacteria in periodontitis. So now we've got a problem. We don't have our PMNs working like they should. We have less antibodies responding to the pathogens. So can you see how smoking really affects the periodontium? Is it making sense now why we had to learn about immunoglobulins and PMNs? Yes. All right. So bone metabolism, this is the third mechanism. And we actually see a lot more bone loss for patients who smoke. There are some studies that suggest that nicotine suppresses osteoblasts. What do osteoblasts do?
Build bone.
Build bone. So remember, B for build. And the mouth is constantly remodeling. So if we don't have enough osteoblasts, it stands to reason that the osteoclasts are destroying bone faster than our body can rebuild it. We also see a release of MMPs. Remember these? Matrix metalloproteinases. There it is. MMPs. So, of course, if we're increasing the release of these mediators and decreasing immune cells and osteoblasts, we're out of that balance. Remember talking about the balance. The host response and the bacteria have to stay in balance. So at this point, the bacteria are winning. They are ahead. Now, environmental tobacco smoke. Did y'all know that inhaled secondhand smoke can actually be more damaging and dangerous than smoking a cigarette yourself? So a lot of states now have laws that parents or guardians cannot smoke with children in the car. Have y'all heard about this? Because those kids don't have a choice. If their parent smokes, that's their choice. But the child does not have a choice. And we see a lot of issues from secondhand smoke. Asthma, lung cancer, all kinds of breathing problems for kiddos. So patients who are exposed to secondhand smoke are at a risk 1.6 times higher of developing periodontitis. And it wasn't even their choice to smoke. That doesn't seem fair. So sometimes for a parent, this is a good way to go. Don't guilt trip them about smoking, but let them know, hey, your smoking habit also affects your child's teeth and the care that they're going to need going forward. So here are some facts that I just threw on here because I think it's important to know about. 70% of patients with alcoholism are also heavy smokers. Smokers are at a 7 times higher risk for oral cancer. Drinkers are at a 6 times higher risk. Well, what if they smoke and drink? This is 38 times higher risk for oral cancer. So if 70% of patients with alcoholism also smoke, they're at a 38 times higher risk for oral cancer. These are numbers that you can back up and use to educate your patients about the potential adverse effects of smoking. Here are some more pictures. What are you seeing in, I'm going to label them, number 1 up here?
Recession.
Lots of recession. We've definitely got some bone loss, right? And you can see it's interproximal just from looking at the patient from a facial view. That's pretty bad. That's quite a bit of attachment loss. Does anyone know what this is in the second picture?
It's a
Is it like? Go ahead, Mom.
Is it a person who dips?
Yes, it is a person who dips. So if you were trying to describe this lesion during clinic, what are some descriptors you would use?
Corrugated.
Good, corrugated. What color is it?
Pale pink or white almost.
Yeah, it's almost white. I would say like whitish. Now, what do you notice about these teeth where the patient holds their tobacco?
Recession.
Some major recession going on. So we would need to specify that the recession is localized to the mandibular left posterior. All right, number 3, what is this one?
Black hairy tongue.
Black hairy tongue. How many of y'all want to kiss somebody with a black hairy tongue? Ew. Can you imagine? Ugh. All right, and then last but not least, what is this 4th picture?
Is that leukoplakia?
Nope, we've extended past leukoplakia, but that's a good differential diagnosis. So you and I are not diagnosing. We would have to provide a couple of options for what this could be. So that's great for a differential. But a leukoplakia would be flat, and it may be kind of hard to see, but here, this is a raised lesion. This is actually squamous cell carcinoma. So do you remember what kind of epithelial cells are most prevalent in the oral cavity?
Stratified squamous.
Stratified squamous. And then here we see a squamous cell carcinoma. So this is cancer in the mouth caused by tobacco use. And this right here is why we should always take our patient's tongue with a piece of gauze and move it all the way to the side. If a patient were just to open their mouth, we might not even see this. This is the lateral border of the tongue here. We might not even see it. So we really have to check the floor of the mouth and the lateral border of the tongue. All right, e-cigarettes. I just call this vape. I think it's more commonly called vape, but in the scientific community, we're calling them e-cigarettes. These do not contain tobacco, so they cause a lot of confusion that this is healthier than smoking cigarettes. But in truth, it's not. And many times it's more dangerous. It's more risky than smoking. So usually there's some kind of metal mechanism used to heat liquid nicotine, and it turns into a vapor. Have y'all seen vaping competitions? I can't believe how much vape people can hold in their lungs. Google it. You will be amazed at what you see on YouTube. So the vapor is inhaled and exhaled, but the FDA just recently started regulating these. For a long time, there was no regulation. People could put whatever they wanted in a vape cartridge. So now we know there are at least these 4 as damaging ingredients. Propylene glycol. This can cause seizures, neurologic symptoms, long-term brain damage. Who is using vape? What population is using vape?
RA or teenage.
Teenage, or what else did you say, Callie?
I said like our age, like 20.
Okay, yeah, teens and 20s usually, right? It's really easy to get a hold of. Gas stations sell this stuff. So in your teens, using vape that has propylene glycol in it, how is that for your brain development?
Prohibits it.
Yeah, not great. Not great. Next, we have heavy metals. So whenever the heating component gets warm inside of a vape mechanism, it's releasing toxic metals from the coil. So we are purposely breathing in heavy metal when we use vape. This can cause lung cancer, neurologic issues, developmental defects. So it's not safe during pregnancy either. It's causing developmental defects. Volatile organic compounds, these can cause irritation. A lot of times we see throat irritation, liver or kidney damage, cancer. Is vape sounding so good now as it was before?
I have a question about the vape.
Sure.
I don't think do most people know that you're not supposed to do it when you're pregnant? Because I've never heard that. I mean, I don't do it, but
It was marketed as an alternative to smoking that was healthier. So a lot of people don't know the actual dangers of it. And honestly, as a whole, we didn't know the dangers associated until recently, until the FDA got involved. Yep, definitely should not be vaping. Nicotine, nicotine can cross the placental barrier. So of course, nicotine is going to impair pregnancy.
can the vape that somebody else inhales cause damage to somebody else?
Yep, absolutely. So according to your book, a lot of the side effects are unknown because there's a lack of research. Longitudinal research is always what we want, but we don't have enough of that yet. What we do know is that we're seeing a lot of cases of popcorn lung. So, in your lungs, you have little air sacs, like little alveoli in the lungs, and they're actually thickening and narrowing. What does that sound like? What systemic disease does that sound like? Narrowing of the airway.
If it's narrowing, is it kind of constricting it because it's going smaller?
Yeah, it's constricting the airways. What are some medical conditions where we see constricted airways?
Asthma.
Asthma, good. So we're essentially giving ourselves asthma by using vape. The symptoms can be very similar to COPD for popcorn lung, and we do see permanent damage. Can you imagine permanent damage to your lungs at 14, 15 years old because you were using vape? Yeah, that's rough. Of course, we see xerostomia, lots of coughing. You know, the problem with vape is how hot that metal coil gets. So when you inhale the vape, it's actually very hot. It's like a hot temperature. Mouth and throat irritation, shortness of breath. Why would we want to use this? Why are we giving this to ourselves? So e-cigs as smoking cessation. What does this word cessation mean? Just means stop. So cessation is like cease, stop. So e-cigarettes are not a approved, recommended cessation technique. A lot of people think I'll vape instead, it's healthier, and then I can wean off of vaping instead of smoking. There is no evidence to suggest that e-cigarettes are helpful in tobacco cessation, that it's healthier than using cigarettes. And then when we look at nicotine, you know, the nicotine content, this is the addictive component. An e-cigarette can have anywhere up to like 15 milligrams of nicotine per puff. It's usually on average like 3 to 6 times more nicotine in a vape cartridge than in a package of cigarettes. So it's highly addictive. Cigars, pipe tobacco, chewing tobacco, hookah, they all have a lot of nicotine. Hookah bars really gross me out. Do y'all ever think about like other people using a hookah hose and then you're inhaling it, especially during a pandemic with a respiratory virus? Ew. Rethink that if you want to go to a hookah bar. Rethink that. Okay, so periodontal therapy. How do you think patients respond to traditional periodontal therapy if they are smokers? Not well. I see you guys shaking your head. Yeah, not well. These chemicals delay wound healing. Why is that? Why would wound healing be delayed? What did we say we're deficient in?
PNN.
Good. PMN activity. We see a negative effect on fibroblasts. What do fibroblasts produce?
Connective tissue.
Good. Collagen for connective tissue. At recare visits, so reevaluation visits, I should say, 4 to 6 weeks after their treatment is completed, they have less reduction in their probing depths, which means they did not have sufficient healing to make their pocket depths less. They have less clinical attachment gain after treatment, and the tissues are fibrotic. So this is tricky. What structure in the periodontium appears as stippling on the gingiva? Y'all know this. Keratinized gingiva, why does it appear stippled?
Isn't it the reedy ridges?
Good, reed ridges, reed pegs, good. So if we've got those same reed pegs connecting the epithelium and the connective tissue, and then we dry out the tissue and lower the blood flow to that area, it makes sense that those REIT pegs would appear more pronounced. We've dried it out. I like to think of this as beef jerky, right? Think of a steak versus beef jerky. Steak has texture. Beef jerky has too much texture, right? Think of that, like the gingiva. Gross example, but it works. So a lot of times, if you see a patient and they don't report that they smoke, when you're doing your perio charting, you might be getting like 5 and 6 millimeter pockets without any bleeding. And that's when we need to ask about their habits. Okay, so how do we think smoking impacts implants?
Does the body reject it?
It might. And remember, the chemicals in tobacco inhibit osteoblasts. How are we getting osseointegration between alveolar bone and an implant? Osteoblasts, right? So if we don't have any, it's not going to work. This is why smoking contraindicates the placement of an implant. The other thing is, remember in the implant chapter, we talked about hard and soft tissue deficiencies, and that if a surgeon uses a burr that gets too hot, we cause damage to the bone. Well, smoking and vaping, as we're inhaling something that was just burning, that heat is not good for implants. We see, healing issues, we see issues with the heat, issues with the osteoblast activity. So smokers experience double the rate of implant failure. How much is an implant? Do y'all know in your area?
A lot. That's all I know.
Yeah.
I know it's not cheap.
It's usually, anywhere, it depends on where you go, right? But let's say, anywhere from $2,000 to $7,000, depending on the procedure you need. Can you imagine paying $7,000 for one tooth to be replaced and then smoking? Doesn't seem worth it for all that trouble. Other risk factors, we see poor biofilm control, history of periodontitis, diabetes. Remember, with diabetes, we're also seeing decreased PMN function, so dysfunction of the PMNs. So if a patient smokes and has diabetes, what does that do to their risk for periodontal disease? Goes way up. So here, where should the bone level be around this implant?
The highest thread.
Okay, so this one has kind of a different loading mechanism. It should actually be up here. I'm drawing on my computer. Up here around the collar. So what's this shape that we see for bone loss around an implant?
Saucer-like.
Saucer or scooped, right? And we've lost quite a bit of bone here, from here to here. And then what are we seeing on this and this?
Calculus.
It might be calculus. What else could it be? Near the crown, what could this be? Excess cement. Remember that when we permanently seat a crown, we're using cement, and we always need to check. Now, from this radiograph, can you and I tell definitively whether this is cement or calculus? Nah, good. We have to consult the clinical exam. We have to consult the doctor and see what they think. And we're actually going to go over radiographs in just a little bit. So tobacco cessation, when did we say this needs to occur for patients who smoke?
Anytime they're in our office.
Every appointment. Good. What are some things y'all would say to talk to your patients about their smoking habit?
Ask them how often.
Okay. How often are you smoking?
How much should I smoke?
How many
Like-
packs are you smoking a day? Good. How long have you been smoking?
Like if they're interested in stopping.
Good. Thank you, Savannah. Are you interested in quitting? And if they say no, is that the end of the conversation? Nope. We still need to talk to them about it. And what do we say when they're like, I don't want to hear the lecture today?
It's my job.
It's my job. And in order for me to take the best care of you that I can, I need to go over this with you. So as far as staging and grading, tobacco use impacts which of those, staging or grading?
Grading.
Grading, okay. So a patient who uses tobacco is at least what?
Grade C.
A B.
A B. They're at least a B. And remember, that's for 10, less than 10 cigarettes per day. They're a C if it's 10 or more cigarettes per day. So this is a really easy way to determine your patient's grade during a case study. If they use tobacco, they're at least a B. What's our other grading, like automatic? If the patient has what's the other one? They're an automatic grade B if they have
Is it less than 7 AC1 levels?
yeah, good. So diabetes. If they have diabetes, they're at least a 7. I'm sorry, a B with a HbA1c of 7. Thank you, Bailey. Okay, so the AAP, the American Academy of Periodontology, strongly recommends the inclusion of tobacco cessation in periodontal therapy. Remember, we talked about the prognosis for a smoker. What does prognosis mean?
What could possibly happen?
Okay, the potential outcome, right, after treatment. Potential outcome, right? So we want a good prognosis. For a patient who smokes, if they can't gain attachment, if they can't, remodel bone like they should, if there's no formation of a long junctional epithelium during healing, what is their prognosis? Not great, right? Fair. So smoking is a really significant risk factor for periodontal disease, and all patients should be assessed for smoking. Is every patient who smokes going to tell you that they smoke? Nope. All right, so what are some hints or clues to you and I that they may be a smoker and did not report it?
Staining.
Staining, okay.
The deep pockets without bleeding.
Okay, pockets without bleeding. What else?
Breath.
Their breath. Good, I was waiting. I knew somebody would say it, their breath. So all of these things, and usually smokers smell like smoke. They smoke in their home, they smoke in their car, you can usually smell it. If you smell it on children, it's important to talk to the parents, is the child around smoking? It could impact the health of their mouth. You still have to give them a heads up about it. So the best thing we can do, ask, do you smoke? Do you use tobacco? And this is the point at which judgment should not be involved at all. We should not be judging our patients about their tobacco habits. We have no idea what goes on in their life. So upon quitting, right away, we see a reduction in pathogenic bacteria. We see improved circulation, improvements in the host response. The lungs start to heal themselves right away, right? We've got tissue turnover. We have cellular turnover. So things start getting better as soon as a patient quits. What do you expect to see more of in the mouth after a patient quits?
Bleeding?
Good. Bleeding. Yeah. We would see some exaggerated bleeding for a while after they quit because their body's just trying to get back to normal, to get back to homeostasis. So even though it's good to quit, some patients get discouraged because they're like, my gums never bled before. Bleeding is a normal response. That's something we need in acute inflammation in order to take care of infection. You might also see that patients are gaining their taste, their sensation of taste back. What would you recommend for a patient with black hairy tongue?
Tongue scraper.
Good. They need a tongue scraper. Every patient needs one, but especially if they've got black hairy tongue. Ugh. So every appointment, every time, tobacco cessation. It takes less than 5 minutes to do this, and you can talk about it while their mouth is open. So they can't really even talk back while their mouth is open, right? This is a great phone number to use. And then who could we refer patients to for tobacco cessation?
Ones wanting to quit.
Okay, where would we say to go?
Primary care.
Go to your PCP. Does anyone know the medication that's often associated with quitting tobacco? Chantix, okay. So if you see Chantix on a patient's medical history, they may be trying to quit smoking. Another one is Wellbutrin, which is technically an antidepressant, but it's sometimes used in treatment for addiction. And in this case, it's addiction to the nicotine. Any questions about the tobacco chapter? Any stories y'all want to share? Don't call anybody out, but no sharing names.
I have one.
Sure.
So I used to work in our ortho department in my office. Now I'm over in like the pedo hygiene, but we had I think he was like 13 or 14-year-old kid come in, and we had to take his plastic Essex retainers away from him, like took them away, threw them away, and not give him new retainers because he was keeping them in, like not taking them out to eat, brush his teeth, nothing, because he thought that was hiding the fact from his parents that he was smoking cigarettes. That like with him keeping those in, that they couldn't tell.
Ew.
Yeah.
They probably stunk so bad too.
Probably one of the grossest things I've seen.
That is so gross. Thank you for sharing that story though. Anybody else have tobacco stories? I have lots of stories. I'm happy to share. I had one patient, she was 18 and she didn't want her dad to know that she smoked, which she's 18. I'm not going to tell dad, it's her business. But she had been going to a pedodontist who did not scale her teeth, and they gave her whitening trays. And she was like, I cannot get my teeth to whiten, and my dad's going to find out that I'm smoking. It turns out she didn't need whitening. Her teeth were beautiful. They were just covered in calculus. So it's important to know that tobacco stain, the extrinsic stain, usually occurs on plaque biofilm and or calculus. And once we remove the calculus, that extrinsic stain is removed from the teeth. So this is why we scale every patient every time, all the surfaces, right? Okay, why don't we go ahead and take a 5-minute break. When we come back, we're going to talk about radiographs. Let's see, it's 1:51. Be back at like 1:57, okay? And I'm going to pause the recording here so y'all don't have to watch 5 minutes of nothing. All right, see you in 5. And any questions from the tobacco chapter before we move on? Any stories y'all thought of you want to share? All right. Okay, so next we're going to talk about the radiographic analysis of the periodontium. And honestly, the first portion of this was really a review from radiography. So I did not include that. Y'all have already taken radiography, okay? So, you know, as far as radiopaque, radiolucent, you already know what that means. Today, we're going to cover some of the normal structures in the periodontium and what they should appear as on a radiograph. And then I have an activity for us to do, and we can do the second case study if y'all would like to do another case study. All right, so when we look at these radiographs, what is this radiolucent structure following the root of the tooth? Radiolucent.
PDL.
Good. That's the periodontal ligament space. Why does it appear radiolucent? Thank
Not a
you.
hard issue.
Good. It's a soft tissue. Very good. Thank you, Kaylee. So the X-ray photons are reaching the receptor without any resistance from hard tissue. What is this radiopaque structure following the root of the tooth?
Lamina dura.
Good. It's the lamina dura. If we were talking about it clinically rather than on a radiograph, what would we call it? The cribriform plate. Good little anatomy review there. All right, so tell me some other things you're seeing. I'm going to number these 1 and 2. What are some other things you're seeing on 1? What are you noticing? Anything?
There's loss of alveolar crest. Sorry.
Okay, so we have alveolar crestal bone loss. Good.
It looks like there's decay around where those fillings are already at.
Okay, so what would we call that?
Recurrent decay.
Good. Recurrent decay. Very nice. Can you see how we have furcation involvement here, where the PDL is widened in the furcation area? Okay. What else do you see? What is this structure down here that houses the inferior alveolar nerve? It's a canal and it's on the
Mandibular canal.
good mandibular canal. Very good. And I know it's hard to see, but what is this radiolucent normal landmark here?
Foramen.
Which one?
Mandibular.
It's the mental foramen. Good. Mental foramen. Okay. What are these marrow spaces called? These normal marrow spaces.
Trabeculae.
Good. Those are the trabeculae. And are trabeculae cancellous or cortical bone?
Cancellous.
Good. Cancellous, also known as spongy bone. Good. Let's see, what else? What do you think this might be right here?
Is it decay?
Okay, it could be decay. What's our differential? Because we're not diagnosing, right? Decay or,
Like a furcation or an abrasion.
well, furcation would be down here, like we call it the crotch of the tooth, right? You meant, what did you say?
I saw like an abrasion since it's
Okay,
not.
more like, okay, good. Now, let's think back to where do we expect to see decay between the teeth? At the contact, right? Well, this is well below the contact, and usually decay goes in what shape? What shape would we expect to see interproximal decay progressing in?
Is it a triangle?
Good, it's a triangle. So this doesn't really look like a triangle, right? And it's down near the CEJ. This is what we usually refer to as burnout. Burnout. And why would we be seeing that? We've got widened PDLs in this area. We've got a broken crown. What do you think this patient might be doing? What habit?
Is it like popping the floss or something? I don't know. Or it looks like there's a little bone loss.
Yeah, there's some bone loss. What could be causing that? If we've got widened PDL,
Clenching,
where,
grinding.
yeah, good, clenching and grinding. So this tooth, the teeth take pressure from clenching and grinding here in the cervical area. So that's why we're seeing burnout there. It's more likely burnout than it is decay. How's our canal here? What's going on with this tooth? We got some problems, right? What do y'all think? There's no right answer. Just take a guess.
Is the tooth resorbing?
It could, yeah, it looks kind of like some resorption here at the root. This could be a vertical fracture. There could be lots of different things going on here, but we know there's something wrong with the pulp, probably because of this gross decay up here, right? Okay, let's look at this one next. Can you see here how we've got this really nice lamina dura, right? Nice and opaque, but then up here, it gets kind of like fuzzy. We've lost that nice continuous line. See here, line, line, gone. It's fuzzy. Do y'all see that? We call that the crestal fuzziness. And it's the very beginning of bone loss when we see that crestal fuzziness. What else are you seeing in this radiograph?
A crown.
A crown, okay. What else? We would have to say that's a suspicious area. You and I know that's decay, but we'd have to say it's suspicious. And you can see how the enamel discontinues here, where the bacteria have just kind of like marched through it, right? So you see the difference between the way this looks, it's at the contact area, versus here for burnout. Are you seeing anything else? It's not a trick question. I just want to make sure everybody got a chance to answer. All right, let's move forward. Okay, so radiolucent, are these dark or light? Lucent is
Dark.
dark, okay. So structures that appear radiolucent on an X-ray, these were easily penetrated and the full amount of energy reached the sensor, whether it's film or digital. So these appear dark gray to black. On a bite wing exposure with no restorations, just all natural dentition, what would be the most radiolucent structure?
The pulp.
Okay, the pulp. There's one more thing that's more radiolucent than the pulp on a bite wing.
The abscess.
Okay, an abscess. What part of the sensor has no hard tissue keeping the photon from reaching the sensor?
Contacts?
Okay, yeah, in the contact area, we should see a nice open area. And why is that? What do we call that? Think about between the maxillary and mandibular arch, like where the bite block goes. What do we call that? The airspace. Have y'all heard that term before? The airspace. So the photons are traveling all the way to the sensor because there's no hard tissue to keep them from getting there. All right, then we said the pulp, the PDL space, a periapical abscess, bone marrow spaces. Now, bone marrow can be a little, bone marrow and sinuses can be a little tricky, right? The maxillary sinus itself is radiolucent, but the floor of the maxillary sinus is not. So it's important when you're looking at radiographs to determine exactly what they're asking about. Now, radiopaque. What's most radiopaque out of this list?
Enamel or amalgam.
Amalgam, good, or gold, right? Metal, because metal is absorbing the photon and not allowing that energy to reach the sensor. On natural dentition, enamel would be the most radiopaque. Same with compact or cortical bone. So when you look at a panoramic radiograph, you see the border of the mandible. That's cortical bone, compact or cortical bone. Okay, so I'm going to zoom in here. Let's see. Is this radiopaque or radiolucent?
Opaque.
Good. And is this more radiopaque or less radiopaque than enamel?
More.
More. Good. How about the pulp chamber here? Radiopaque or radiolucent?
Radiolucent.
Good. How about this marrow space?
Radiolucent.
Good. Radiolucent. How about this enamel here?
Opaque.
Where's everybody at? Callie, does your back hurt? Because you're carrying this conversation, girlfriend. Where are you at, guys? Wake up. Wake up, wake up. So it's important to recognize that radiopaque and radiolucent are on a scale. We hardly ever say something is completely radiopaque or completely radiolucent. It's all on a scale, right? So this here is the airspace where it's black. That's the radiolucent airspace. So let's talk about the periodontium. The normal level of the alveolar crest is about 2 millimeters apical to the CEJ. What tissue is making up that 2 millimeters around a natural tooth?
Connective tissue?
Okay, connective tissue. So there's usually 1 millimeter of connective tissue. And then if we've got 2 millimeters total, what's that other millimeter?
Epithelium.
Good, the junctional epithelium. And together, what do those describe? We talked about a violation of this space when we place restorations. What is that called?
Biologic width.
Good, biologic width. So it makes sense why there needs to be 2 millimeters from the CEJ to the crest of the alveolar bone. It's difficult to detect bone loss on radiographs unless it's, around 3 millimeters. And the reason for that is the density of bone. We have to have differing levels of density. So when we take a radiograph, what KVP setting are we using in dentistry?
$80.
It's usually just a little lower than that, right? 70. 70 is like ideal for KVP. You were very close there. Usually 60 or 70. Now at 70 KVP, do we provide high contrast or low contrast?
Low contrast?
Good, low contrast. And is it black and white or many shades of gray?
Many shades of gray.
Good, many shades. So the way I like to remember this is that high KVP produces low contrast, many shades of gray. Up, down, up. And the opposite is also true. So if we used 60 KVP, would we have high or low contrast?
High contrast.
Black and white or many shades of gray? This would be black and white. What would this be good for diagnosing if it's black and white? We said many shades of gray is good for perio, right? For you and I, that's an appropriate use. What if it's black and white? What do you think we could see very easily on those radiographs?
Decay.
Decay, good. We would use these for decay, perfect. Does that help with the KVP a little bit? I know that's a really confusing topic. Okay, so we've got all these little details, right, about the periodontium. So we talk about horizontal bone loss. Now, before we even look at any bone loss in this image, can you see the lamina dura, how it's a nice solid line following that alveolar crest? That's how we want this to look. Now, I don't really like this picture as an example for horizontal bone loss because there's really not a lot. Maybe we've got some crestal fuzziness here. And when we draw a line from CEJ to CEJ, we're pretty parallel there. So here's the illustration, the horizontal contour, what we're looking for. Now, is this illustration accurate? Is the alveolar crest at the CEJ? How many millimeters apical is it?
2.
2, because we've got to have room for that junctional epithelium and connective tissue. Good. Now, vertical bone loss. Remember, we need to draw our CEJ to CEJ. And if it is no longer parallel, right, like this one, this is even pretty close, but you can see those two lines are not parallel. That would be a vertical area of vertical bone loss. What are we seeing here?
Calculus.
Calculus. Good. Okay. Now, how's the bone loss looking on these radiographs?
Vertical.
A little rough, right? We got some problems here. So let's draw CEJ to CEJ. And then the defect here, is that parallel? Nope. So that's vertical bone loss. Okay, now let's draw our lines for the root surface. So we've got one, we're gonna guess because we can't see the whole tooth. This bone loss, is it in the coronal third, the middle third, or the apical third?
Middle third.
Okay, middle third. So this patient, when we think about their stage, their AAP stage, if we are into the middle third, what stage is this patient at least?
3.
Good. Stage 3. So remember, if we're into the middle third, the patient is at least a stage 3. How about this radiograph? What are we seeing here?
Is it more fuzzy? So
It's pretty fuzzy, but look at where the CEJ relationship is, right? And we've got bone here. So let's split again. We're gonna go 1. Let's see, that's about the line I needed. 2, 3, 1, 2, 3, and 1, 2, 3. Which of these areas has the most bone loss? We're kind of borderline, right? So let's go with the distal of number 3 here. Is that 3? Yes. I think. I don't know. 14. I'm out of it. All right. Bone loss. Coronal third or middle third?
Middle third.
Good. So we're at least a stage 3 there. Here, I would call this a stage 2. I think we're still in the coronal third, just barely, but we're there. And then up here, do you see what I was talking about for the floor of the maxillary sinus versus the maxillary sinus itself? Radiolucent versus radiopaque. Okay, so we cannot treat a patient without x-rays. A comprehensive exam is not complete without radiographs. We can see changes in the bone, the tooth morphology, the maxillary sinus. Why might we need to see the maxillary sinus?
Maybe infection.
Okay, infection.
To see if the tooth pain is related to sinus issues.
Good, to see if tooth pain is related to sinus issues the patient may be having. And then placement of what? Implants, good. Widening PDL space, remember that can be a sign of periodontitis at the beginning. Furcation involvement, abscess, local factors, all kinds of things can be seen on the radiographs. That being said, are radiographs used exclusively to diagnose and treat a patient? I see some yeses and some nos. Why do you feel the way you feel? Do radiographs have limitations? Yes. Okay. How do we make up for those limitations? What do we do?
Look at them clinically or refer them out to their primary care or a different specialist.
Okay, so we have to look clinically. Can we tell a patient's pocket depth from a radiograph? And we need that, right? We need that to treat their perio. Remember that a radiograph, oh, I have to skip a bunch to go to that. Okay, a radiograph is a two-dimensional representation of a three-dimensional object. What kind of bone loss would we not see on a radiograph? We know we see interproximal bone loss, but what kind is not readily clear?
Like the density?
The what?
I said like the density of the bone. Can you tell that in a radiograph?
Density? Okay, you can interproximally, but not facial or lingual, right? We can't tell if a patient has lost bone, facial or lingual, based on a radiograph. So there are some things we can't see. Can we tell if a patient's bleeding from a radiograph? Nope. So they're great, but we can't use just these images. So radiographic signs, you know, in the beginning, we'll see that fuzziness, that crestal fuzziness toward the, you know, once we get some progression, we're going to start seeing furcation involvement, bone loss, things like that. So first we see the fuzziness, then the widening of the PDL, and then the radiolucent lines in the interseptal bone. That's where the density comes in that you just asked about, Callie. So let's go back a ways. How's the density here as compared to here? Is this area more or less radiopaque than this area?
Less.
Less radiopaque. So what does that say about the density of the bone between the premolars?
It's thicker.
If it's less dense, yeah, it would be less dense, and that's why it's showing up darker, more radiolucent here. This is more radiopaque because it's more dense. Would maxillary alveolar bone or mandibular alveolar bone appear more dense on a radiograph?
I have a question.
Okay.
Is there something going on that premolar? With the radiolucent around the root?
It could, not, I don't think so. You're talking about this. It's just that these marrow spaces are really not dense anymore. This patient may have osteoporosis or something like that. All right, where is the bone more dense, the maxilla or the mandible?
Mandible.
The mandible. What does that mean for local anesthesia? Is it easier to anesthetize the maxilla or the mandible?
Maxilla.
Maxilla, yeah, of course, because with that less density, we've got more blood flow, more nerves, right? Things like that. Okay. Going back. Triangulation, I'm not going to focus a whole lot on this. This is mainly widening of the PDL, and you're going to see it right here. This is triangulation, where we just got a triangle where the PDL space, you know, has separated more from the bone. What should interproximal alveolar bone look like in the posterior? Flat or sharp?
Would it be flat?
It's flat. Thank you, Ashley. It's flat. Okay, so here, this is sharp. We got a problem. We would want to see flat alveolar crests across there. Now, these finger-like projections, what are these called? These radiolucent lines. These are nutrient canals. Do y'all remember that from radiology? Nutrient canals. And these occur when the patient has disease and the body is trying to help. All right, so limitations. Remember, this is just a snapshot in time. This can change day to day. You know, this can change from radiographer to radiographer. This reveals what's left. How much bone is left between the teeth rather than how much a patient has lost. Like we said earlier, this is a 2D image of a 3D structure. We cannot see buccal or lingual bone. And then palatal roots. Which teeth have palatal roots?
Three.
Okay, 3 and 14. So maxillary molars have palatal roots. And sometimes we can't see furcations in these areas because that palatal root is like superimposed. So what can radiographs not detect? Periodontal pockets, early bone loss, mobility. Now, of course, we may suspect mobility if we see a widened PDL, but without a clinical exam, we can't confirm mobility. And then level of epithelial attachment, we can't see that. Sometimes we can see the level of gingiva, like the margins of the gingiva, but not epithelial attachment. So bite wings, this is a national board question. So if I take a PA, Moana takes a PA, Aylin takes a PA, Faith takes a PA, and Ashley takes a PA, are those all going to come out exactly the same?
No.
Probably not. If we take bite wings, if all 5 of us take bite wings, will those come out more similar than the PAs?
Yes.
Yeah, it's a pretty standard technique across the board for bite wings. So this is why these are the best. These are the most consistent. Also, we can see the alveolar crestal bone in relationship to adjacent teeth, right? All right, let's practice and look at this radiograph. What are we seeing here? Anything?
An amalgam.
Yeah.
Okay. Amalgam.
You can see that interproximal. I don't know, I'm just saying stuff.
Yeah, interproximal. You can see the air spaces interproximally. Absolutely.
Bone loss.
Bone loss. Okay. So we've got CEJ to CEJ, bone.
Is there
CEJ.
decay?
Okay, there's some decay here, here, here. See how this one has broken through the enamel and we can see it in the dentin? How about this?
Is that calculus?
Some little spicules of calculus. Good. So radiographs can tell us a lot. Can it tell us what the depth of the pockets are on these teeth? Nope. Okay, so a lot of times in furcations, we don't see furcation involvement in the radiographs until it's gotten pretty serious. Now, obviously, this is furcation involvement, right? Do you think we would be able to at least get our neighbor's probe into this the furcation? Yeah, probably a 3, if not a 4, depending on where the tissue is located. You can see that the patient has calculus. All that is calculus. All that is calculus. All this is calculus. Not a very healthy patient, right? So let's talk about calculus. Large interproximal calculus deposits are sometimes visible on radiographs, but it's completely dependent on the level of mineralization of that calculus. If we can visualize calculus based on the radiographs, it's going to help us remove the calculus. So once y'all start seeing patients, I want you to really look at your radiographs. If you see interproximal calculus, I want you to take your ODU 1112 and really check that area. That should be a nice clickable spot of calculus to help you develop your tactile skills. Now the paralleling technique, this is the most accurate technique when compared with the bisecting angle. However, it's less comfortable for patients. What are some advantages of paralleling technique? I'm really testing you now, right? Taking you back to radiography. All right, we have less distortion. What's an example of distortion that could be present on a PA?
For shortening.
For shortening, elongation, right? Using the paralleling technique eliminates that, or it should. It's easily repeatable between providers. So we should get a similar image between providers if we use the paralleling technique. Does everyone use the paralleling technique? Mm-mm. And then for contrast, what did we say the KVP should be at for our purposes?
60 to 70.
Good. So probably 70 is about ideal. 60 is good for detecting decay. 70 is better for perio. When to switch? When do we need to use vertical bite wings instead of horizontal bite wings? How do we know? What are some of those clues?
Deep pocket depths.
Okay, deep pocket depths. If y'all take a horizontal bite wing, and you can no longer see the interproximal alveolar bone, you need to ask your instructor, can I take vertical bite wings instead of horizontal? Don't expose all 4 bite wings if there's no alveolar crest on them. Then they're not useful for our purposes, okay? So here's a set of vertical bite wings. Tell me something you're seeing on the first film.
Root canal treatment.
Okay, root canal. Looks like silver points almost. It's too radiopaque to be gutta percha. So we have root canal therapy. What are you seeing here? This is actually furcation involvement. Up here, we got calculus, definitely some bone loss. Up here, this is a great example of seeing a furcation on a maxillary molar, even though we have that palatal root, we can still see that furcation involvement. So there's a lot going on in vertical bite wings. Okay, let's do an activity. In the module for this week, I have placed a set of radiographs, an FMX. And I want you to take about 10 minutes. I'm going to pause the recording after we get the instructions. I want you to take about 10 minutes and look through the radiographs and just write down whatever you see. The most important things that you have to write down. What do you think their 1999 AAP is? What do you think their 2018 AAP is? So for the 2018, you will only have a stage because you don't have any patient information about a grade, okay? So AAP case type for 1999, AAP stage for the 2018. Feel free to write down any anomalies, anything you see, just like you would. And then the other thing I want you to write down is interproximal calculus that you can see on the radiographs. I'm going to go ahead and pause the record. Okay, so we've got CEJ to CEJ, and then here's our bone loss. So we've definitely got vertical bone loss, and you can actually see the beginnings of frication involvement where we have widening of the PDL there. All right. How about this radiopaque structure?
The
Is
sinus.
that the maxillary sinus?
The floor of the maxillary sinus, because I said radiopaque. Good. Okay, let's go to the next film, number 3 to 5. What is this?
Where the pulp should be.
Yeah, it's a pulp stone. So we're actually seeing a pulp stone there. And again, we do have some bone loss, some pretty vertical bone loss there. All right. Number 5 to 7, what are you seeing?
Is that overlap some?
Yep, it is. So for this film, what contacts should be open?
Is it the interprox? The between the teeth one? The
Yeah.
interproximals?
Which teeth? For a canine PA, which teeth should we have an open interproximal space?
6 and 7.
Good, 6 and 7. Okay, so overlap. There's calculus here and here. So we've got number 7 mesial, number 8 distal. We also got 8 mesial and 9 mesial. What is this radiolucent structure here?
Is it a nutrient canal?
Well, it's a normal landmark, but that's a yeah. It could have been, right, if it wasn't a normal landmark. What is that structure in the mouth?
The incisive papilla.
Okay, the incisive papilla would actually be down here. And we would call it the incisive foramen on a radiograph. And then clinically, that would be the incisive papilla. So up here, what is this structure inside the mouth? Instead of the roof of the mouth, we call it the
Palate.
okay, the palate. It's in the middle. So it's the
Mesial.
median palatine suture. This is where the maxillary process during histology, right? During formation, embryology, those shelves of the palate flip up and fuse. So this is that suture that fuses those. Okay. Number 10 to 12, how are we looking?
Overlap.
Good, overlap. 12 to 14, what are we seeing?
Calculus.
Calculus. Little bit here, here, here. And then 14 to 16. Overlap. And then again, CEJ to CEJ. So this patient's got some bone loss going, right? Okay, 17 to 19, what are we seeing? Start shouting it out. We're running out of time.
I'm missing 18.
Okay, missing
19.
19. Yep, there it is. It's okay. I said 3 for 14 earlier. It happens. Missing 19. And then what is 18 doing because 19 is missing?
Medial drift.
Mesial drift. Got that long tooth lean going. We also have some calculus here on the distal of 18. How are we looking here, 19 to 21? What are we seeing?
Bone loss.
Okay. Bone loss. What else?
Calculus.
Calculus. What else? It's actually a nutrient canal. You see that radiolucent line? Anteriors, what are we seeing?
Some crowding.
Crowding for sure, good.
Lots of calculus.
Lots of calculus, yeah. And then again, with those nutrient canals down here. All right, and let's look at the posterior films here. What are we seeing?
Some overlap.
Good, overlap.
Bone loss.
Bone loss for sure. Little furcation involvement. Again, it looks like he's got a pulp stone forming here on number 30.
Would you say that 30 and 31 have some burnout?
Yep, I see that here. Burnout. Good. Okay, and then what is it called when the roots are like squiggly like that? Do y'all remember that word? Dilaceration. Dilaceration is when the roots look kind of funky. Okay, let's look at these bite wings. What do we think for this patient's 1999 AAP? What's their case type?
Two.
2, okay. Why do we say 2?
Because there's bone loss and calculus.
Okay,
present.
so the calculus, right? The calculus is not causing the bone loss. Remember, it's a contributing factor because it's always covered in.
Plaque biofilm.
Good, I saw a few of you say plaque biofilm. Okay, so the case type, when we look at this patient as a whole, remember 1999 case type goes as generalized. And generalized, I'm seeing that this patient has 3 to 4 millimeters of bone loss interproximally. So I would call this a case type 3. Now a stage, what stage do you think this patient is? We're going based on the worst area, the most involved area.
2.
B.
2? Why a 2?
Because it's a 3 to 4 millimeter loss.
3 to 4 millimeters of loss. Okay, but in the very worst spot, let's look specifically down here. CEJ. Bone loss. Are we in the coronal third, the middle third, or the apical third?
Coronator.
Where is this here? We're into the middle third for that one tooth. So because that's the worst area, we're into the middle third. We're at a stage 3 for this patient. All right. Okay, what do y'all think? What do you think of those x-rays?
I think it was
Pretty rough.
helpful to review.
Oh, good to look through it. This is my board patient. This is my patient that I took to boards when I was a student. And it was hard. He was a calculus 4 and he had flared canines that were overlapped with the laterals. He had overlapping in the posterior. It was just like the hardest x-rays I've ever taken to this day. All right, we have just a couple minutes left. Any questions from today before we finish up? No questions, nothing? Okay, so don't forget, we have an exam on Tuesday. And the exam, I did upload the updated schedule to the module so that y'all can see what's going to be, covered each week. But for the exam, we'll only go up to this chapter that we covered today, 21. Chapter 20 is not included. You were already quizzed on chapter 20 toward the beginning. So if y'all have any questions, please let me know. And if not, I hope you have a wonderful day. Thank you for coming to lecture today.
Is chapter 17 going to be on this exam?
Yes, I believe so.
Okay.
Because we didn't have it on the quiz. The quiz was 15 and 16. So yeah, 17 will be on the exam.
Okay, thank you.
Uh-huh.
Miss Mitchell, we just add
Yes.
17 on there, so it'll be 18, 19, 17, 18, 19, and 21.
That's correct. That's correct. All right, y'all. Thanks for coming today. Have a great day. Bye.
Oh, Miss Mitchell, were there handouts for today's lecture?